It's great to be up here for the reason I was asked to come, which was to talk about our program in the United States, and I'll do that over the next 15 minutes or so and try to give you some examples of some of the strategies that we think are being effective in implementing interventions that are increasing the number of people becoming aware of their status and getting into care and successfully treat it, while also identifying some of the challenges in that regard that we're trying to work on for the future. First of all, we do have strategic plans or action plans for the United States. They've gone through 3 versions, and I bring them up just to, again, acknowledge the importance of planning, and we've heard from other countries that plans are available, so it's just it's very important because it really it helps you develop that comprehensive approach that Margaret was speaking of and help you bring together various stakeholders in your health system and in your community, more than one individual or one agency trying to do all of this alone. It's really not possible. In the United States, we're really battling 2 epidemics. We have an epidemic of morbidity and mortality among people who were infected with HCV many years ago, particularly before the virus was discovered in 1989. So it's creating this bulge in our line graph of people being infected by age. Because they're moving through time, we talked about their birth year or birth cohort, and we have targeted the 1945 to 1965 birth cohort in the U.S., the so-called baby boomer population, because they have a 6-fold higher risk of HCV than other adults. 81% of all infected persons, adults, are in this age group, 73% of all deaths with an average age of 59 years. At the same time, over the last 5 years or so, we've had an increase in the incidence of HCV. The number of new infections is going up among young individuals, particularly people between the ages of 20 and 30. They tend to be white Americans, equally male and female. And in contrast to the HIV epidemic among drug users in years past, they tend to be in small cities and in rural areas. And we're going to talk a little bit about each of these. Now, this baby boomer population is a sick population. They have been infected for many years. Many of them were infected because of health care, blood transfusions, poor infection control. Some undoubtedly were infected through injection drug use. That comes through in our national surveys, but 80% do not report any current injection drug use. So there's really no reason to require this population to acknowledge those kind of behaviors when it's not part of their current lifestyle to get access to HCV testing and treatment. So we've adopted a demographic or population-based approach rather than a risk-based approach. And because they're ill, and this just was a recent paper showing that about half of the baby boomers now have moderate or severe fibrosis, and this is a work done by Homi Razavi for the United States, showing that the morbidity and mortality will continue to increase if we don't do something different to intervene and get people tested and cured. So we adopted a recommendation for a one-time test for all persons born in these years, in addition to the previous risk-based strategies, particularly related to testing people with a history of injection drug use. For the benefits that hopefully most of you in the room recognize with viral clearance of HCV and reducing morbidity and mortality from liver disease and extrahepatic manifestations. And we thought we could have a sizable impact of averting over 300,000 deaths with even moderate implementation of the birth cohort strategy. We are not a large division. We have about 2% of the budget of the HIV program at the CDC, for example, but we did have some limited money to put out some resources for public education as well as provider education. This is just one example of billboards that billboard companies put up free of charge. We just provide the artwork for that. This was in Atlanta, but I see them pop up all over the place. And it is having some impact on testing. This is data from the so-called market scan database, which is tens of millions of clinical records in the United States. So you can see there the line in the red. When we introduced this recommendation in 2012, that was followed by an increase in testing of the baby boomer population, although only about 3% getting tested every year is not optimal, but it is an improvement over the baseline. Also, the reason for that testing is changing. As you can see there, if you look at the 2014, the reasons for testing has shifted from workup for liver-related findings to general medical findings, more of a prevention medicine screening rather than a diagnostic workup. So it does seem that there is some behavior change going on among providers. But we recognize that the testing needs to be improved, but then what happens after that testing also needs to be improved, the so-called care cascade of getting that individual linked to the right care and getting the right treatment. And there's a number of different barriers in that regard. We have estimated previously that only about half of the individuals who get a test for HCV antibody that's positive is then tested for the RNA to diagnose current infection. Only about a third get into current care, and then only about 11% are in treatment. So how do we improve that? And let me give you about 4 ways that we can improve that care cascade for HCV. Number one, if you want to improve the number of people getting the RNA test who are HCV antibody positive, you can implement reflex testing in your laboratory, whereby that same specimen that's collected and tested for HCV antibody is then saved and then tested for HCV RNA if it's found positive. This shows you two of the largest commercial laboratories in the United States. One, Quest, implemented reflex testing where they put that specimen aside and then tested it. And the other one, LabCorp, did not. And you can see the dramatic improvement in the number of individuals getting that test, or proportion getting that RNA test if they were HCV antibody positive. So reflex testing. Sorry. Secondly, patient assistance for individuals who are not familiar with the health system. This is a study we did in Philadelphia among Black and Hispanic Americans, many of whom did not have regular sources of care. They implemented a case management system to help the individuals navigate our health system, which is not always straightforward. They found a high prevalence of HCV antibody, as you can see there, successfully tested them for RNA, and got large numbers into care and for someone knowledgeable about delivering HCV care. So patient assistance. Secondly, clinical decision tools, whereby you have little reminders in a clinical electronic medical record, so when that patient checks in, there's a pop-up reminder for that clinician to order that test, or that test gets ordered automatically by a standing order format. This is from the Indian Health Service of the United States, where they implemented that clinical reminder, and within 3 years, the proportion of persons in this baby boomer cohort successfully tested went from 7% to over 30%, and in some of clinics over 70%. And the most successful ones were the ones who had implemented this clinical decision tool. So using electronic health records in that way is helpful. Moving care out of the realm of specialty into primary care. This is, again, a study we're doing with the Cherokee Nation, which is part of the Indian Health Service in the United States. They've committed themselves to an elimination strategy. Dr. Jorge Mera is the champion of that in the Cherokee Nation. But just to show you that about a quarter of the persons being treated in the Cherokee Nation are actually being managed by pharmacists. And another third, I didn't have time to show it here, are being managed by nurse practitioners. So they've totally moved, largely moved their care out to mid-level providers. It's another strategy. But we do have some barriers. Number one, we have a treatment cost barrier. treatment costs came in very high, between $84,000 and $96,000 per curative course in the United States. It has come down through a variety of different actions. The U.S. government reminded state Medicaid, that's our public treatment clinical care programs, that they needed to follow national recommendations for treatment. Other drugs came on the market, which made the market more competitive. Various systems began to negotiate lower prices, such as our Veterans Administration system. And then there were some legal actions where patients took health plans to court, leading that health plan to relax their restrictions. And about a third of the states have lessened their restrictions, but as you can see in this map, the states in red have very restrictive policies now. So we have very much a patchwork quilt of access to treatment based on insurance criteria. So a very unacceptable situation, but one that we have to deal with. Moving on to the younger population who are HCV infected, we've had about a 150% increase in incidence. About 28 states are affected. They tend to be in the southern and eastern part of the United States, as shown there in that middle map, a very rural part of the country, and it's related to a return to injection of either prescription opioids or of heroin. Another byproduct of this epidemic, regrettably in the United States, because these are affecting young people, is that women of childbearing age are becoming infected, pregnant women are becoming infected. Rates of HCV among pregnant women are rising, as well as infants exposed to HCV at the time of birth. So we've had an increase in the United States, whereby now about 1 out of every 300 births is to an HCV positive mother. In these states that are most severely affected, that's even higher. 1 out of 67 births is in the state of Kentucky. I went to one of the small towns in Kentucky in July. They told me that 50% of the women in the perinatal clinic in that town were HCV positive. We're trying to do a variety of different things. We're trying to help states investigate these social networks, both epidemiologically as well as using new next-generation sequencing technology so you can help map out these networks and really understand how to best intervene with them. And we've made that application web available so that more states and maybe around the world eventually can use this system and ease their access to the use of this technology. Now, thanks to Peter Vickerman, who's here here at this meeting and will be talking tomorrow, we've been doing he's been doing an evaluation of the relative benefits of different interventions, and just to demonstrate here that for a Cochrane review, that syringe service programs, particularly based on European data, have an impact in interrupting transmission. What's not often as discussed is that medication-assisted therapy also has a sizable impact on treatment, on acquisition of HCV. Putting those together, you can prevent over 70% of transmissions. He then went on to show how you could enhance your prevention even more by testing and treatment with variability based on the incident dynamics of different populations, and he has modeled that in different countries. In different cities in the United States. One of the problems we have in the United States is that there are variable access to these interventions. The United States has tended to adopt somewhat of a moralistic approach to prevention by feeling like if you make available syringe service programs, you're going to promote that behavior, which we know is not the case. And so only 18 states authorize syringe service programs out of the 50 states in the United States. Only 27 states allow retail sales of injection equipment by pharmacists. So we have a long way to go in that regard. So you can see we have a real disconnect. This is a map of diagnosis of HCV among people 15 to 29 years of age, and then the triangles show you where syringe service programs are located. And you can see that there are large swaths of the country that do not have prevention interventions where HCV is happening among young people. And indeed, only 20% of these individuals live within 10 miles of the syringe service programs, and some more than 300 miles away. So we have a lot of work to do in the United States to correct this. There's also restrictions that if you are a drug user, you are denied access to HCV treatment. Again, you can see a number of states have those restrictions in place. So it's very, it's really nonsensical to deny treatment to persons who are actively engaging in behavior that can transmit to others. You want to give them a full package of interventions, including treatment, to reduce that risk. And we don't want to forget about corrections. The issue for the corrections in the U.S. is that it varies by state, but as you can see here, prevalence is high, whether it be in the federal inmates in the U.S. Prison system or the state prison systems that we were able to get data from this recent analysis. With differences being whether they had a risk-based approach, which probably means they just were testing people who were very sick or had a knowledge of they were injection drug users, versus those that were testing all the prisoners as they came into there. We have a variety of different activities going on to get a handle on this epidemic of HCV among drug users, looking at prevention research about how do you best treat HCV, as well as how do you find individuals in the community and get them into care. We're strengthening surveillance to better detect persons who are newly infected, and then helping states develop syringe service programs. Our planning in the United States is moving into an elimination framework. We have the Institute of Medicine looking at this. They've already put out one preliminary report saying that elimination is feasible for the country, and then they are developing goals that they will release in March of 2017, and we're looking forward to that so that we can begin to discuss about elimination for the country. So we have a lot of work to do. We have good interventions that can cure over 90% of infected individuals. We can prevent over 70% of new infections. It's just really a capacity issue and a commitment issue for the United States, and we hope that we can begin to change that dynamic by issuing these elimination goals and letting everyone in the country know what's possible. Thank you.